It's time to start the second part of today's exercise. So my name is Oskar Nordström-Skans, and I'm editing this together with Harry Flam, who forgot to introduce himself initially, so I'll do it exposed here. Next speaker is Lars Hultkrantz, who will speak about the value of life. Nothing more dramatic than that. I guess Lars is with us online. And there, as before, it will be 30 minutes for Lars and then 15 minutes each for the commentators and then general discussion after that.
So, thank you. I was just invited to be a panelist. Thank you very much. I hope you hear me. Actually, this presentation will, as the paper, be made jointly with Professor Mikael Svensson from Sahlgrenska at Örebro University. So I will start the presentation, and then Mikael will take over some part of it, and then I will return to you. And we have agreed that I should share the presentation. So let's see if I can find it on my here. I hope you see it now. Can you please tell me if you do? Obviously not. Then I do a new try. Here, do you see it? Don't hear anything from you. I'm changed. Do you see it now?
Yeah, we can see it now.
Okay,
can you
fine,
please just
fine.
put it in presenter mode?
Yeah, but I don't get that. I have to do it.
I think if you click view.
Yeah, but that where is it? View is here, isn't it?
Yes.
No, it isn't. I normally have it down here at the bottom, but
if you
that's
press
hidden for me.
F5, then it should work.
F5.
Yes.
F5.
No.
No.
Otherwise, if you go to slideshow at the top.
Yeah, here I have it.
Yeah,
okay.
And from beginning.
Yeah. Okay. Now we're on, I hope. As I said, this is a joint effort with Mikael Svensson, and the title of our work is The Economic Cost of COVID-19 Illness, the case of Iceland, Norway, and Sweden. So what you understand from this is that we have done a so-called cost of illness study, and not a full-fledged cost-benefit study, and that we have studied so far only 3 countries: Iceland, Norway, and Sweden. We cover the period of the COVID-19 from the start in early 2020 until our data so far ends, which is August 15 this year. Main reason for this is, of course, that there have been a lot of decisions made during the pandemic in all countries, and they have a very large extent involved making trade-offs between economic consequences and health consequences. Already in late spring and summer 2020, that there came several economic evaluations of different policy measures and decisions that had been made, and comparison between the countries and so on. Normally using cost-benefit analysis, and often trying to model the pandemic, its consequences, and the interactions with the overall economy. And in retrospect, it's clear that some of these models were too simple, and that our understanding of these trade-offs and of the policy measures were not very complete at that time. And still, I would say that we really don't grasp all the aspects of the COVID-19. But it's very clear that we are doing and will do a lot of ex post evaluations to understand what we did and how we did it, and what we can learn from, for instance, school closures, as we heard about in the presentation before lunch. When you look at the early economic evaluations made in May, June the last year, it's very clear that both that they used different models of the pandemic and how it spread and its ramifications in various ways, but also that they took different approaches to the economic evaluation of the health consequences. So the basic aim of this study is to provide a basis for cost-benefit analysis of policy measures during the pandemic, and so very much of our effort is on discussing how to make these valuations. So it's a cost of illness assessment and not a full cost-benefit analysis. So now it's time for some background, and Mikael will give that. Over to you, Mikael.
Okay, thank you, Lars. So I'll present some brief health backgrounds to our paper and our cost of illness analysis that we will present here. Most of this, of course, will be no news to the attendees of this conference. But among these three countries, Sweden, Iceland, and Norway, Sweden had the very first case, at least as far as we know, of COVID-19. I think, if I remember correctly, January 24th, a woman returned from Wuhan, China, and was later on confirmed ill with COVID-19 in the Jönköping region in Sweden. And of course, as we will see later on in the results, and as is also well known to everyone here, Sweden is by far the country worst hit by the COVID-19 illness among these three countries. But although the first case differed in time slightly, by the end of February, all three countries had reported their first case, and especially, I guess, after the February-March school holidays, there were a lot of media attention, of course, surrounding the returnee cases from the Alps and so on. So by March 2020, there were community spread in all Nordic countries, more or less. So Lars, if you continue. And then, of course, as a kind of background to our cost of illness analysis, the policy approaches have varied, I mean, both across countries as well as within countries, as also have been the case during the entire pandemic, especially, I guess, in 2020, mostly pronounced. Sweden has been a kind of international poster boy for a less strict approach, where we have relied more on recommendation and less on laws and regulations. I mean, true in the Nordic region in general, and of course also true in the comparison between Sweden, Norway, and Iceland. If we look at some background that we will get back to later on in terms of the outcomes as well, Iceland was among these three countries early very active in test and tracing, for example, to just take one example. And is the country still today among these three countries with the most accumulated use of test and tracing. As another kind of a case in point, Iceland has also been the most successful country in vaccinating its population, comparing Iceland, Sweden, and Norway. These data points are a few weeks old, but at that point anyway, probably higher in all three countries by now, slightly higher anyway. A few weeks ago, around 80% of the Icelandic population had double jabs, compared to approximately slightly above 65% in Norway and Sweden. But also, I think the when looking at the development over time, international assessments have shown that differences in policy strictness have been less pronounced as time passed, and especially difficult to assess, of course. I mean, different indicators can be used to assess policy strictness. It's not like we have a specific lab test to assess the degree of strictness. This is just one example from the Our World in Data project that have a COVID-19 stringency index, which is based on 9 indicators. And as we can see here, especially Iceland and also Norway had a higher kind of strictness early on in the pandemic, but it's been kind of varying over time. And also, of course, policy response is kind of endogenous to how the pandemic develops. So increasing strictness could be, of course, also a cause of a more problematic situation, and vice versa. But I think in terms of the health consequences of the pandemic in these three countries, as we'll see later on, there's going to be no news to the general finding that the health impacts, and thus the monetized health impacts, has been highest in Sweden. Lars?
Okay, it's you or me?
Go ahead, please, Lars. Yeah.
Okay. Okay, I take over now. So what we have done is a cost of illness analysis, and basically it's about putting an economic value on mortality and morbidity consequences in the population from the prevalence, or as in this case, the incidence of a specific disease. So the task is to identify, quantify, and value these losses. And normally, what is most important in that the analysis is not the direct costs or the indirect costs in terms of, for instance, people being on sick leave, but the human cost or non-tangibles, the losses of lives or losses of health, various non-tangibles that are very important when it comes to the results, but more difficult than the other cost components to put a value on. This is a general overview of our model. We value both mortality and morbidity consequences, and both mortality and morbidity gives rise to health losses. Mortality, of course, because of death, and morbidity because of illness. Morbidity also gives rise to costs for the healthcare sector for various kind of treatments, and it also gives rise to production losses due to sick leave. In our work we include all these aspects. So we include the healthcare treatments using a cost per patient data. Mikael will talk more about that. A human capital approach, which is basically a loss of production measured with the wage income, and we value both mortality and morbidity. And the main approach we have used is to base health effects expressed as quality adjusted life years, and so-called QALYs, and that can be applied to both mortality effects and to morbidity effects. So the big and difficult question is how to value health effects, and in our case how to value the loss of quality adjusted life years. So the conventional approach in the cost-benefit analysis, which also is often applied to transportation and infrastructure investments, is to put a value on fatalities, expressed as the value of a statistical life. So it's a valuation where you don't differentiate between different people, only taking into account that they are deaf, and that's quite natural in the case of transportation traffic, because car crashes can kill anyone, both young people and old people, and so it's on an aggregate scale, it's quite natural to put an equal value to every fatality. But when it comes to illness and different kinds of illness, it's often the case that there is a specific age profile of mortality or fatalities, and so in many cases it is reasonable to differentiate the value according to age. And if we as we do in conventional cost-benefit analysis are based on consumer preferences, the Hicks-Kaldor paradigm, so to say, then we want to look at how much the willingness to pay for reductions of mortality risks vary with the age of the person who is doing the expressing a value, a willingness to pay, and both from theoretical reasoning and from empirical research, we have reasons to believe that this value of statistical life increases in young ages, and then declines in older ages. And for the range of ages that is relevant here, it is reasonable to believe that the willingness to pay, or the VSL, and the sum of welfare declines with age, or more exactly with the expected remaining life years of the victims. So that's we would expect lower VSL values to be relevant for the effects of the COVID-19 pandemic than we would have applied for instance in traffic safety applications. Also, it's noteworthy that in the consumer preference approach, willingness to pay is normally increasing with income and with the wealth. So rich people can afford to pay more than poor people. An alternative approach is to use a social welfare function. You can call it a citizen preference approach. The approach citizens would take perhaps when they are electing their political representatives, and also in such approach, you would expect that BSL or the social welfare is declining with age. But on the other hand, you would expect that people want to compensate more to people that are poor than people that are rich. So social welfare in such analysis normally would decrease with wealth. The approach we take here is the perhaps not a conventional, but rather often used approach in health economics to express consequences to health in terms of quality adjusted life years, and therefore to put an equal value to every quality adjusted life year lost, independent of whether it is lost because of death or because of illness. And in that approach, since every life year has an equal value, it means that old people who have less remaining life years will get a lower value than young people. On the other hand, in this approach, every person has the same value. So the valuation is independent of wealth and income. We discuss the choice between these approaches in the papers very much against the background of theoretical analysis that has been published quite recently by Herrera Araujo and other people that have tried to illuminate how this health economic approach can be related to the principles of consumer welfare, ordinary cost-benefit theory. And in short, one can say that using an equal VSL would very much overestimate the welfare losses. The approach we have taken is can seen as a conservative assessment of the welfare losses. So it gives a minimum value of the welfare loss. Okay, from that you have to find the numbers. When it comes to the value of statistical life, there are several studies that try to overview all value elicitation research that has been made in many countries over the years. When it comes to the value or willingness to pay for a life year or a quality adjusted life year, there has not been so much systematic reviews. Actually, one of the first reviews was made by Mikael Svensson and a co-author, but very recently there has been published a rather large such systematic overview article in the European Journal of Health Economics by two Canadian researchers, and that is basically their regression results that we rely on in our analysis. In this table, I will also show what values you would get if you use this kind of V value or willingness to pay per quality value if you derive them from the official value statistical life numbers in Norway and Sweden. And these values, method B, have not been computed by us, but we have for Sweden, it's a value computed by one of our discussants, Ulf Persson and Sara Olofsson, a couple of years ago, and we also show a similar value that has been presented by Helsedirektoratet in Norway. Method C is not a value derived from the utility or consumption side, but a value that derived from the cost side or the opportunity cost, and it's values that have been estimated by, once again, Mikael with colleagues in a study of in a revealed preference study of the decisions made by the Swedish government agency that decides on subsidies to new pharmaceutical drugs. And as you see here, method A gives slightly equal values per quality adjusted life year in the 3 Nordic countries. Slightly higher actually in Norway, and that's because GDP per capita is higher in Norway than in Sweden and Iceland. And you can also see that these values are in the same range as the threshold values or opportunity cost values that Mikael and his colleagues have estimated in the revealed preference study, while the values derived from the official VSLs are higher, and that is precisely as what you would expect from the theoretical analysis that I talked about previously. So what we use here is basically method A, and we use the same value, you could say the Swedish and Icelandic value to value mortality and morbidity effects. Over to you, Mikael.
Okay, thank you. So this table outlines the main assumptions that we plug into our cost of illness model that Lars showed in a figure a few slides back. And as Lars mentioned, also one very central parameter assumption is the value per QALY that we, at least in this version, have the same value for all three countries. Perhaps in revised versions, one could also consider then using the slightly higher value for Norway. But I mean, some of the main assumptions, not going to go over all of them, but we look at and we conduct the analyses both looking at total deaths reported with COVID-19, which is, as we can see, almost 15,000 in Sweden. So this is up to August 15th, slightly less than 800 in Norway and around 30 in Iceland. Then we also do a cost of illness analysis where we look at excess deaths, which is kind of peculiar in this setting because two other countries are quite unique in an international context by having no estimated excess deaths. So that's the case for Norway and Iceland. Actually, they had less deaths than expected during this time period if you look at time trends and predictions and so on. The number of excess deaths in Sweden that we plug into the model is 10,320.
Oh, Mikael, can I just interrupt just to let you know that you need to reach the end within 5 minutes?
Yeah, perfect. Thank you. And we also, of course, another central parameter is the number of cases and the total inpatient days that we use to, so the number of cases we use to assess morbidity, valuing morbidity consequences. The total inpatient days we use to value the resources to treat cases. Finally, I'm going to mention also the number of QALYs that we assume per each death. So we assume 3.33 QALYs, so healthy, perfectly healthy life years. We assume that each death is associated with an average of 3.33. I mean, this is a number that is lower than some other published estimates. So we take this from a recent publication in Health Economics made by some Norwegian authors, and slightly lower than some estimates, but on the other hand, not perhaps that surprising given that almost half of the deaths are in among the elderly care home population, where we don't have any systematic data for the three countries, but some case studies indicate that expected life expectancy in elderly care homes may be 1 to 2 years, and so on. So Lars, since we're running out of time, I think we should head into the results. So using these main assumptions, we plug them into our cost of illness model. And what we have here is a table of the monetized health consequences from the COVID-19 pandemic in the three countries. So they're summarized based on the monetized impact from deaths, from excess deaths, from morbidity, from inpatient days. So that's the treatment costs. And then the sick leave, that's the lost production value using a human capital approach. And then we have the summary estimates, or the summaries, both total for each country. So that's total with deaths and total with excess deaths, depending on if we plug in the number of total deaths or the number of excess deaths in the model. Go back, Lars, please. Yeah. And then we have also per capita numbers. So if we focus on first the total numbers, we have around 8 million euros for Sweden, around billion, around 665 million euros in Norway, and 48 million euros in Iceland. And the per capita numbers, 777 in Sweden, 122 euros in Norway, and 138 euros in Iceland. So significantly higher in Sweden and quite similar numbers in Norway and Iceland. Yeah. And I think we can skip. We also did some sensitivity analysis using Monte Carlo simulation, but I will let you now, Lars, end the presentation with some conclusions.
So if you compare our cost estimates with annual GDP, the largest cost is on Sweden with 1.4% compared to annual GDP, while Iceland only had 0.1% and Norway 0.22%. But of course, all countries have had a large GDP losses, especially during 2020. So we can conclude that overall the total costs of the pandemic has been very large in all countries. And finally, what we have done is a very conservative assessment. We have used the V value, not the VSL. So if we had used the VSL, as several analysts did last year, we would have got values that had been more than 10 times larger than those we have, especially for Sweden, of course. We have used excess deaths, not total deaths, and we have not included post-COVID effects. So I think that's the summary of our report. Thank you.
Okay, excellent. Thank you, Lars and Mikael. Then we turn to the first discussant, who will be Ulf Persson, who I see is on standby. So you have 15 minutes. We're running a little bit late, so be vigilant on the time, please.
Okay, thank you very much. And hope you can see my slides as well. Can you see my slides?
Yes.
Great, perfect. Thank you very much, both Lars and Mikael, and thank you very much for inviting me to be a discussion on the paper. And it was really a pleasure to read your paper. And I will try to go through and see if we can. First, I fully agree with the relevance and the purpose of the paper here. I mean, you say that in different variation in policies, and variation is always very interesting. So we should absolutely try to use that, see if we can. How we can use it to learn something about policies for COVID-19, and also to establish an economic analysis and related assess the economic cost of it. I suppose that you're actually trying to find some basics for cost-benefit analysis of COVID policies, even if you not perfectly spell it out in that way. I think that's really what you're trying to do later on. And this is actually one of the points that I would like to bring up here, because you're talking about the cost effectiveness, cost of illness analysis. And you're also talking about the cost benefit cost analysis. And you're also talking about the costs in different ways and health losses. This is a little complicated from my point of view about the terminology. Because I know that we use the terminology in a little different way in transport economics than what we do in health economics and so on. But I think this is important because there has been a lot of misinterpretations and misunderstanding about what we are talking about when we're talking about costs and values of health losses. And you know everything here, but I think it's important to be careful about the terminology, because cost of illness is an estimation of productivity loss due to morbidity and mortality. It's a positive analysis, not a normative analysis. It has its grounds in the cost of war by Robert Griffin and Clark and Dublin and Lotka, who was actually trying to answer the question how much should a man pay in insurances to get money enough to save the family if he would die. So that's a slave calculation, more or less, and that has been used in different crazy ways. Then a little later on, it's Dorothy Rice who made the cost of illness, started to use these estimations for costing loss of production and mortality, cost of productivity loss due to mortality and morbidity and so on. So that's completely different from valuing health. On the other hand, when you go to benefit cost analysis, it's a normative analysis. It's based on willingness to pay from Abraham, T.D., Schelling, John Slee, Mission, etc. You know all of this. And the quality adjusted life years is actually something completely different also. Quality adjusted life years first came up in the United States by Bush, Shannon Patrick, and was transferred over to Europe later on through the development in the Euroqual index and so on. That's a health index, trying to get one measurement of longevity and quality of life at the same way. And I think this can make it difficult to interpret when you're mixing everything together and call it cost of illness. I think you should be very, very careful here and be very stringent in using the terminology here. At least as you think about it, if you shouldn't change it a little bit here to be very stringent, actually. And when we're talking about the outline of the study here, that's also some problems when you are talking about cost of illness here. In fact, I know that we are talking about intangibles in transport economics, but it's a quite different language when we are using it in health economics. I think you should be careful as well here about it. I have a specific question here when you are estimating the quality loss per case, because you're using 3 years per case. I think this is quite good. We used the general population's expected overall survival for everyone who died, and then we came up to about 6 years per case. I think this is an overestimation. I think 3 years is much better, but I would suggest, if you have some evidence for it, or if you have something that you could use as a reference for it, I think it would be great. And the same is about the lost production per case and so on. I would be happy to see a little more details about how you actually came up with that figure. Then we come to the value of lost quality, and that's the different approaches that you have just explained. in a very nice way. I think this is a very good section in the paper. And I think this is one of the most important contribution you have in your paper about that. On the other hand, I wonder if, in what way, when we're talking about the implicit cutoff thresholds, because this is the study which is done by Mikael together with some of the TLV people, and it's based on earlier decisions by the reimbursement authority in Sweden. I think this is close to something that means that we have included the budgetary restrictions in it, because real decision making includes something that we can say that we are trying to internalize budget limitations in the cost effectiveness when we are doing it in that way. So I think this is one way. For TLV, for example, they started with a VSL approach, and then the figure for a quarterly has been decreasing over time as the region's budget limitations has been more and more pronounced into TLV's decision making. So in general, I absolutely agree with it, but I think you are the approach that you are using is a little bit influenced by budgetary restrictions, and that's what we used to call internalizing budgeting. I'll go on to the outline of the paper. I think this is very reasonable and so on, and as I can see that you come up with the figures here, that will be about 34,000 quarterlies lost in Sweden, as an example. And that means that we will go to the limitations here. You are talking about that you don't include post-COVID into it, and of course I understand, because it's no data probably on it. But my question here is, why don't you try to include also the quarterly loss due to different policy actions here, the non-pharmaceutical interventions? They have been estimated not only by myself, but also in different US research groups, and also in a recently published Lancet publication about the depression and anxiety. And this is from many, many countries around the world. And when we made our estimations, we came up with quite high figures based on NPIs, and we came up to something in regions of 30,000 to 40,000 quarterlies lost per month. If we are talking about your estimation of excess mortality, it's for a whole year. That's for 12 months. So we are in about the same magnitude per month. I think you should have a good argumentation why you should take that out and not include it if you use the definition of the health loss due to COVID and the preventive activities and so on. And I actually, I think everything is I agree with everything what you have done otherwise, and I agree with your conclusions and so on, have no problem with that. But my suggestions is to be careful with the terminology on cost of illness and resource utilization and health loss and so on. And my suggestion is also you can make a choice, perhaps. I will limit the scope of the estimation to the lost healthcare resources, lost production, lost health related to morbidity and so on, diagnosed with a disease, or wider the perspective and include a broader estimation of lost resources and lost health by including NPIs as well as another aspect also, and that's the crowding out, the waiting list, the cardiovascular diseases, the cancer treatment that has not been done, and because of we have to take care of all the COVID patients. We haven't had time to do that as well, or resources to do it. So I think you should consider to broaden the perspective or limit the perspective. And there's also, the conclusion about GDP and so on was also about the terminology, I think. And my suggestion is also that you should add a section where you tell us a little bit more about how the model should be used and how we should, the best way to do it. Is it for different preventive strategies, or is it for estimating the value of COVID vaccine or whatever? For example, I think it can be used for that. So
Ulf, you are out of time, essentially. Is there a final comment?
Okay. But just summing up the what I had just said, I think it's not only it's the lockdown cost, and it's also the lockout costs, so to say, that should be considered to be included as well in your estimation. Sorry for going over time. Thank you. And thanks for a very nice paper.
Thank you all for extremely interesting discussion. I will leave it to Lars and his co-author to comment on this at the end. But first we have Tuulia to present the other set of comments. Again, you have 15 minutes and we are slightly more over time, so be even more vigilant on time. Please, Tuulia, the floor is yours.
Thank you. I don't think I get the...
sorry, Ulf, can you stop your screen share?
Okay, still disabled. Disabled share. Oh. Okay. And now here we go. Well, first of all, thank you for giving me an opportunity to comment, learn something about totally new methodology that I haven't crossed paths with before. So thank you for giving the opportunity and to comment on this today. Even though the paper is very methodological, I'm not going to comment on the methodology mainly because I'm not able to, and plus, even more importantly, I don't think that's the point of Nordic Economic Policy Review. So I'm going to comment on the economic policy bit, and mainly because that's when Nordic Economic Policy Review was launched, at least in Finland, that was the aim that we aimed for. I took a bit from the internet site in terms of what this paper should be, or what the review should focus on, and colored some of the bits here. And it says latest economic research accessible to decision makers, and then thinking of what does accessible mean. It probably means more than you can download it from the internet. It probably means readable, understandable for decision makers. So that's what I'll be trying to focus on. What would I understand? What would I, if I were to work at the ministry, what would I tell my minister about this paper? What are the conclusions? How does it help us to make better economic policy? So the research question in the study, as we have been over in the presentation, is that you try to put a number to indirect costs that are due to COVID. And I guess the big part is that there were premature deaths. Deaths would have occurred anyway, but then there's this concept of excess deaths, where there are more deaths than would have been in the contrary had we not had the pandemic. And then there's also a number put on the working time that was lost due to pandemic. What's special about this paper, as far as I understand, is that it uses a different methodology that it used before. It uses this excess deaths rather than deaths in general, and then it uses evaluation. It puts a different number to a year lost, depending on which age it has been lost. So pretty heavy stuff in terms of the sort of ethical evaluation, in whether 1 year when it's lived in a different sort of profile of at a different point of your life has a different value. Nevertheless, interesting thing. So what could be the lessons for economic policy from this type of calculations? Well, first is obviously you try to put a number to indirect economic costs of the pandemic. So looking at this cost, is that whether it's big or small, or how does it compare to GDP fall? That's interesting in itself. If I were to push it a bit further, in terms of for policy discussion, then I guess one would could suggest that it could be discussed that who pays for this loss, because somebody will need to pay for it. Does it need to be this generation, or are we going to share it with the future generations? Or are we starting with the position that, say, previous generations have saved up enough that we can use these savings to pay for it? So which time frame, who will pay, and how? Obviously interesting for, I mean, it's at the root of policy discussions in probably every country that I know of. The second point, if I were to report it to the political decision makers, it would be this trade-off between health and economy. Can we put a number? Can we put them in the same sort of at the same level that we lost GDP loss? We can evaluate in terms of, we can put a number to it. Can we put a number, equal number that we can compare to the health loss, and how much the health loss actually meant to the GDP? Should there be a trade-off? And if there is a trade-off, how does that affect the restrictions? What do we do with the restrictions, which are really the policy variable that the politicians have control over? So that would be probably my second angle if I were to talk with the politicians. Yeah, like I said, that I view these with the test of what would I tell my minister about this paper. So these probably would be the angles. I know you probably will hate the second bit at least, but nevertheless, this is what it probably would be used for if people at the ministries would be reading this and talking to the politicians. So looking at your results, interesting results. There seem to be different numbers in the text compared to the table, so probably want to fix that. So at least I wasn't sure which ones were there. The final figures that you came up with, and for me the interesting bit was that you put the number, you took up what was the GDP fall in these three countries. You also put the number in terms of the cost of illnesses. I mean, that's the final result is what was the result in terms of GDP, if you consider that. Now I wasn't quite sure, do you add this up or do you take the how would you, if I were to answer my second question in terms of that, which of these three countries fared best out of this, out of the pandemic, and then coming back to it, what were the best policies that were used? This is probably what I would work with. So to conclude, I would probably push this paper. I know this is something that academic economists are careful with, but this is the direction I would still push it for, because this is the interesting bit in terms of that. What do we learn in terms of policy from this paper? But thank you. That's my comment. Thank you very much.
So thank you, Tuulia. That was just brilliant, because we're now back on time. So I guess next we let Lars and Mikael respond to what was said, and then we see if we have additional questions.
Do you want to start, Mikael?
I can start. I want to thank both discussants. Very good insights. Ulf had a lot of methodological insights and comments, and I don't know, I guess I agree with Ulf's comments, so I don't have that much to add there. I mean, the number, if anything, I can mention just that we assumed that each death implies 3.33 lost QALYs or healthy life years. It's based on a study that also tried to adjust for the comorbidities of the deaths from COVID-19. So not only looking at how old they are, but also that, you know, for a given 85-year-old, for example, the person dying from COVID-19 had more comorbid conditions and probably a lower life expectancy than the typical 85-year-old, and so on. So that's a published paper, not from us, but from partly some Norwegian authors. Also the policy comments, I guess. I mean, yeah, I guess it's correct that we try to be a bit cautious here, because there are so many uncertainties and so on. Maybe I'll leave that point to Lars if you want to mention anything. I mean, the final point, I also want to note perhaps Ulf's point about the cost of MPIs. I mean, that's a very relevant point, I think. So probably something we should discuss, me and Lars, how to approach. Lars?
Thank you. I also want to thank both discussants. I think you both gave us some things to think about for the continuation of this work. In a way, both of your comments has to do with the limitations of the work, and it's true that we are somewhere in the middle of a very basic cost of illness analysis and something that is heading towards cost benefit assessments of policies. The main problem with what you ask for, Tuulia, is that it's not only necessary to have measures of economic values to do a policy analysis, but you also have to have knowledge about effects, causes and effects, and the sizes of effects from various measures or treatments or actions on health consequences, on the mortality and morbidity. And I'm sure that there will come more and more such assessments. For instance, when we're talking about school closures, as we learned today, there are specific costs for losses of the future wage income for the young people that had remote learning, but probably that there were some benefits as well in terms of avoided mortality and morbidity. And if you have such assessments of impact, then using our numbers, it's possible to make a full cost-benefit analysis. But we are still in the pandemic, and there is very much we need to know more before we have good such impact assessments. Also, as Ulf said, more and more knowledge is coming about other effects of the COVID than those that we have included, such as surgeries that have been postponed, long-term effects, not only post-COVID, but also long-term effects on productivity. So for instance, last week a study using sports data from Germany and Italy on performance of football players, and it seems that those that have suffered from COVID are performing significantly less, have lower productivity very long time after the illness. So there are a lot of other consequences of the COVID-19 that we probably could, some of them could probably be included when we finish this paper, because as time goes, more and more information is coming. So I think that's the basic way we will develop this paper, is to include more cost components in the analysis. Thank you very much.
Good. Do we have any questions in the audience here? Oops. Oh, that was close. Yeah. Christina. Christina, wait, come here. It's going to be fast.
Okay, just a very small comment. We have this lot literature which has documented that people that lose their jobs, are more likely to die. So we actually have even estimates on how much every 10,000 job losses increase mortality of individuals. So I'm just wondering that in these kind of calculations, do you take into account even the immediate costs of the restrictions of or the possible job losses on health? So that was the only comment.
The answer is that we haven't included that type of indirect effects, but I don't know to how much we will be able to do that, but possibly.
I guess if the mortality effect is more or less instant, I mean the instantaneous, at least within this time period, would be captured in the kind of total deaths or total excess deaths. But But I mean, if there's an increase in mortality risk over time, I mean, that is something we would not have captured, no. So be my slight revision of that answer.
I just wanted to comment on the comparison between GDP and the loss of life, because it's not a simple comparison. As for Iceland, you had a huge contraction, mainly due to some external factors and not because of restrictions. That's just a small comment. But then I wanted to ask, because you use the cases, as I understand it, to estimate the morbidity, the effects of morbidity. Here in Iceland, we had these extensive track and tracing procedures. So a lot of Icelanders have gone many times to do the tests. Is it of any concern that in a particular country you would catch more of COVID cases than in other countries? I've heard stories about people, for example, in Sweden that didn't have, they were told not to come for tests, even though they were sick at home. So is that of any concern, or that's simply my question?
Mikael, it's a question for you.
I guess if they become severely ill and then end up at hospital, it wouldn't really be a concern because they would be there in our data. Of course, if you compare, worldwide and you have different healthcare systems where some people would be more or less not admitted to the hospital, even if very ill, I mean, that would be a concern. I don't see that as a major issue for the severely ill in any of these three countries. For the morbidity effects, where we've based the data on the number of cases, yeah, I guess there could be a risk of bias due to the comment mentioned here. I mean, if anything, I guess the kind of non-fatal morbidity costs could be underestimated due to that reason. There is a risk of bias there, yeah. But I guess we don't know if it differs between the countries. I mean, anecdotally, maybe, especially, I mean, Sweden was quite late in allowing population-wide testing. So, I mean, that could be true, yeah.
Any more questions? So then I will ask a final one. I was intrigued by the comparison of the NPI costs and the costs of morbidity and mortality suggested by Ulf. So is it a fair comparison to compare the two? And so should we conclude that even in Sweden the cost was 12 times as high from the NPIs or not? So that was a quick answer.
The reason we in the conclusions present the reductions in GDP is just to give some way of relating the cost figures we have. So it's not a component of the cost benefit analysis.
But the estimates that he suggested on the loss because of restrictions in terms of quality adjusted life years said was at the same order but by month as the ones that you estimate by year.
Yeah. That's a very valid criticism. So
criticism. I mean, would it be fair to say that that one of the conclusions from your estimates is that the welfare losses from mortality and morbidity were much lower than which is what you estimate, right? And then what he estimates is the welfare losses from NPIs?
I think that could be a fair, I mean, I would be slightly more worried about the validity in the, I mean, since we base our numbers on actual deaths and registered cases, I mean, the consequences of, or the loss qualities from MPIs or kind of restrictions or lockdowns, I mean, I guess it's going to be much more difficult to estimate. So I think we should be a bit cautious. But I mean, taken at face value, I guess, yeah, that's the conclusion then.
Okay. Well, I guess you can think about that for the final version, but
yeah.
it's pretty pretty strong stuff, I guess. But anyway, thanks a lot for the presentation, the draft, and for the comments and the questions and the answers.